Hi, this is Dr. Inkyong Parrack. Welcome to Whiteboard Wednesdays. We're going to talk about carotid arteries and its association with stroke. And today we're going to focus on cleaning out the carotid artery and what that means. So I get asked a lot of questions about, what does it mean to clean out a carotid artery? There are three different ways. We've talked about this in other Whiteboard Wednesday topics that you can click on. There is a way of opening it up, which is carotid endarterectomy or CEA, where we go in and scoop out all the plaque. There's a way where we go in from base of the neck and we fracture or kind of bust the plaque. All of that plaque gets sucked out of the body along with blood, gets filtered and then given back. And then we line stent in its place, which is called TCAR or TransCarotid Artery Revascularization. And then there's a method of Transfemoral Carotid Stenting, which is going from the groin or the arm and going up to the carotid artery and then putting a stent and ballooning it open. So there are three big methods of fixing your carotid artery with our current technologies. And so what does this mean and what are the realities of these methods? The goal of carotid artery surgery is stroke prevention and preventing any sort of other minor microembolization that may lead to things like dementia. So when we talk about embolization and the carotid artery affecting our brain, what it means is as the carotid artery starts to build up plaque disease, it's going to not be necessarily a nice smooth plaque, but most of our plaque has a little bit of jagged edges. As the plaque builds up over time, the flow dynamics of the blood vessel is such that there's going to be higher velocity of the blood flow that is going past that segment of blockage. You can think of it kind of similar to going down a stream in a canoe. As you start to go down in a stream, in a wide open stream, you're going to go down like this. But if you go into a very narrow stream, aka the stenosed blood vessel, your canoe is going to go down at a much higher speed, like this. As the blood goes at a faster speed, it can crumble or knock tiny little pieces of that plaque, and that plaque could either go to the brain and cause a stroke, or that kind of abrasion process where it causes irregular surface of the plaque causes our body to look at it as an area of injury. And what does our body do when it's injured? It puts a clot on it, right? So that it doesn't bleed. So then our body comes and puts some clotty material in it, and that clotty material then goes to the brain and causes a stroke. So these are all really the mechanism of stroke. It is very rare that you have diminished blood flow going to the brain secondary to blockage of the carotid artery that's causing a stroke. The lack of blood flow is at the level of the brain that causes a stroke, not from all the way down in the carotid arteries. With that in mind, the goal of carotid artery surgery is going to be cleaning it out or getting your carotid artery to the point where things are not going to crumble and go to the brain, right? And things are not going to clot and go to the brain. That is going to be the goal. So it doesn't necessarily matter whether we're getting it down to 0%, 1%, 2%, as long as we get it down to a clean surface where nothing's going to crumble or, cause an abrasion and cause a clot and go off to the brain, we've succeeded. The second is that going to stay that way? So for the future, it may look nice right now, but for the future, it has to be so that it continues to look clean enough so that it does not become a problem later on down the line. These days, carotid artery surgeries are happening at many different ages. Just like, when you look at patients who have cancer becoming younger and younger, we're having a variety of ages that have some of these carotid artery disease. So if you are looking at somebody in their 40s and 50s getting these surgeries and people live to their 90s very commonly these days, then we have to have a durability of the surgery or the intervention for 30, 40 years down the line. So that's the second question. The third also very important question is when we're doing the surgery, there is a very distinctive risk of stroke. So from just cleaning out carotid arteries alone, what we're essentially doing is crumbling and taking out the plaque. And that process itself, you can imagine tiny little flecks of the plaque then going to the brain during the process. So what is that risk with each one of these procedures and how do we prevent it? That's the biggest thing. So let's kind of delve into one thing at a time and talk about scraping or cleaning some of the carotid arteries out. If you manually were to go in there and scrape some of these carotid artery stuff, what we essentially do is we clamp out the carotid artery on either end. We sometimes have what's called a shunt, meaning we have a tube going from one side to another, a tiny little tube, so that some of the blood flow is going into there while we're cleaning it out. But essentially, the main blood flow through the disease segment of the carotid artery is completely isolated from the rest of the brain so that we can effectively look at the plaque, physically scrape it out, make sure everything is clean, and then sew it back up. It's a very great process. With this, you can clean out all sorts of lesions. It doesn't matter whether you're growing a sticky plaque. It doesn't matter whether you're growing a bone inside your blood vessel, which is essentially what a lot of people do these days, getting calcific, disease within their blood vessels, meaning it's as if you're growing bone within the blood vessel. So with the cleaning out technique, I can clean all sorts of things out, make it look nice, make sure that there's no debris remaining, close it off. As long as you are done by somebody who is trained in this and who are proficient in this, and as you know, all of 6 of us in our vascular surgery practice are board certified vascular surgeons, this is exactly what we've been trained to do over years and years of practice and over kind of unimaginable hours in the hospital. So with this process, we can guarantee you that the artery is going to be good. Even with this expert trained hands, if we look at on average in national numbers, there's about 1 to 2% risk of stroke from just the carotid endarterectomy surgery on its own. It's because during the manipulation, during dissection, getting down and clamping and sometimes scraping things out, little bits and pieces can theoretically break off, go to the brain and cause a stroke. There is also a possibility when you cut off the blood supply altogether to the brain, that the brain is too starved for blood all of a sudden, right? It's unlike when you have slow progression of disease where a brain starts to take more blood flow from the other side. All of a sudden you clamp this up and the brain is shocked, and then you can actually have some stroke symptoms from it. These are some of the reasons why you have that 1 to 2% risk of stroke with carotid endarterectomy. Let's take TCAR next and see how that process treats the carotid arteries. So you first go into base of the neck. So we're all the way down here where the carotid artery does not have any disease. So we're going to get into a really clean area, and then we're going to be able to establish a flow reversal system, meaning all the blood flow now is being sucked backwards, not toward the head and to the brain, but away from the head into a canister that is positioned outside of the body. And all of that blood goes through a filter, and the clean blood then gets given back through an IV that's established during the surgery as well. Obviously, you're not aware of any of this because you're either numbed up, even though you're awake, or you're completely asleep. So when we establish this blood flow, an interesting thing happens where our blood flow is not completely stagnant, unlike when we do carotid endarterectomy and we have to clamp things off. There is some circulation, even though it's going in the wrong direction of brain flow. We don't know if that's what the benefit is, but there are some patients, like when they have complete blockage of the other carotid artery on the other side, some of these patients actually benefit from doing this procedure because then you don't have both carotid arteries completely stagnant at the all same given time. At least one side is providing some movement, even though it's going in an opposite direction. Once that flow reversal has been established, we go in with the balloon and we actually basically crack the plaque, and all of this plaque gets dislodged. Some of it gets then squashed against the wall, some of it gets crumbled, and all of that gets sucked out through the flow reversal system into the filter that is outside of the body. Once it's completely filtered outside of the body, then it's going to get clean blood given back again through the groin. Once this happens, it's going to look much better. It's going to look kind of like this. But because it doesn't look perfect, then we lay a stent in its place to make sure everything looks beautiful and nice and smooth. At the end of the day, there will be a stent in its place, but it is going to be placed within a lumen that is much better cleaned out so that it is not a stent that's going into a narrow area and being a little bit compressed or squashed. It's going in within a really nice cleaned out area to make the whole area look smooth. So the stroke rate from doing this surgery is also in the about 1 to 2%. It's not lower than carotid endarterectomy, not higher. It's almost exactly the same. And if we follow these patients over decades, the outcome is also the same, meaning is it better to clean it out in terms of going and scraping out the plaque? Is it better to then go in and break up the plaque, suck it out, and then put a stent in its place? There's really virtually no significant difference as far as the outcomes that we know so far within the science that we know. The third method, which is transfemoral carotid artery stenting, is also a very good method, but it is for very select patients. Up until about maybe 5-10 years ago, this was a lot more commonly done, and I was a part of a system where we did a lot of transfemoral carotid artery stenting. So this was something that I'm very, very familiar with, and we used to do a lot of. One of the things, though, that even though we take people who have done a lot and then are considered experts, essentially the process and the mechanism, unfortunately, lends itself to higher risk of stroke. So even in expert hands, it goes from 1 to 2% to now about 4 to 6% risk of stroke from transfemoral carotid artery stenting. And we think the reason may be because in order to get there, we're not all within the area that we want to target, but we have to come from somewhere far away, either from the groin puncture or somewhere in the arm puncture. And then we have to navigate our way through the other arteries to the area of interest. And most people who have plaque disease within this area also have plaque disease in other parts of the body. So navigating through that, sometimes it can cause some of those plaques to then get dislodged and go to the brain. And so this is one of the reasons why there's a slightly higher risk of stroke from this. The second part is the protection is considered a little less suboptimal. So when we do transfemoral carotid artery stenting, we go in and we put a stent and we blow it up. Again, we say transfemoral, so it usually comes from the groin, but we do it from the arm as well. We go in and we initially put a stent after putting in a filter above that. So we have a little mesh filter that's kind of above the area where we're going to be doing the stenting that's theoretically supposed to catch materials that gets dislodged. I can tell you from having done, a significant number of these, if you look at that filter, I'm not even sure if there was one case where there was anything in the filter. So I think it's not possible that there's a zero plaque that gets dislodged. So the fact that we catch nothing in the filter tells me that some of this plaque are at a concern of breaking off and going to the brain. And that's why probably the stroke risk is a little bit higher. But the other part of it is that the stroke risk is something that we immediately see when the patients are in the hospital, meaning how are they doing when they wake up from surgery? Are they moving the same way? Are they smiling well? Is their face drooping? Is there any concern? So as long as that is not a concern, then we say, okay, you did fine. You're not in that stroke, from the operation. You did well. If you take all of these patients who got carotid artery surgeries in one manner or another, and you scan their brain with MRI, sometimes you see this little tiny flecks of something that must have broken off and gone to the brain. And they look like these tiny little white spots on the MRI. And if you trend the patients and take those patients that have tiny little specks or dots in your brain MRI after a carotid intervention, the more specks you have, the more likely you have dementia later on in life. So even if we're not quite catching what's happening in terms of stroke just from doing the procedure right now, all of this has implication that it may build up and create significant outcomes of AKA dementia later on in life. So because of this, it gets very tricky when it comes to cleaning out your carotid arteries. We do need to be able to know which one is going to be the best for you. And there has been now multiple published articles that say if your surgeon knows how to do all three things, and if your hospital can provide all three of these things, then the patient outcome outcome is much better as an institution as a whole, which means you want to go talk to somebody who can counsel you in all three different possible surgeries, which myself and all of my partners are able to do all of these three surgeries, and I'm very comfortable with that, so that we can pick out the best way to clean out your carotid arteries so that we protect you now as well as protecting you 10 years from now. And thank you for joining me on carotid artery surgery and how to best clean this out without causing you any issues. See you next time. Thank you.